Our next session here is going to be on lower extremity reconstruction. And I'm going to start with the same disclaimer that Ivo gave. Somebody gave me this title, but we'll make a go of it. So the title of my talk is Indications and Outcomes of Fancy Wound Goo and Expensive Gauze. Or as most of my colleagues say, just tell me what to put on the wound. So we'll start with the most fundamental of, what should you expect from a wound dressing, or what should be your goals with selecting a wound dressing. And the first one is maintain a moist wound environment. I think all of us have enough experience to know that. Manage the exudate, so if the wound is highly exudative, the peri-wound skin will be damaged by these exudates that leak out. You want a dressing that stays in place and minimizes shear, friction, and skin irritation, and select a cost-effective dressing, especially if you can pick one that's changed once a day or less. Obviously, it's a big reason why probably the VAC, which does most of these things, is such a popular dressing choice. But these are the goals you should have in mind when you're thinking about selecting a dressing. So I have this table, and it just basically goes over the different kinds of dressings and what their indications are. And yes, I know it's small, and I apologize for that. Basic categories: foam dressings for very highly exudative wounds. All of the dressing categories that I'm going to tell you about come in an antibacterial form, one way, shape, or form. And again, some examples. We have Manuka honey is a big one. Silver, my one caveat to that is things are definitely resistant to silver, so it's not the be-all and end-all. Chlorhexidine, and some cheap dressings, Curlix, AMD, and Xeroform. Alginates, again, for highly exudative wounds. Hydrogels, which are cross-linked gelatins. You can use those for desiccated wounds if you want to do some autolytic debridement. Hydrocolloids, again, they are for superficial wounds with minimal exudate. Hydrofibers, charcoal infused. Occasionally, if you get some of those fungating tumors, those are really helpful. The ones that are on the market tend to be expensive. You can sort of jerry-rig some with an ABD pad, and actually the charcoal that you use in fish tanks. Barrier creams is another big one. I actually like this a lot when you're talking about trying to protect against exudates. They come in antifungal. They're frequently over the counter. They're inexpensive, and they do a good job at protecting the peri-wound skin, especially for things like continence issues. And then this last one, these protease modulating matrices. So these are your Permagran, your Prisma, your Puricol. Basically, wounds have very high levels of proteolytic enzymes, and in my opinion, these serve mainly as a substrate for those proteolytic enzymes, so they're dissolving the dressing and not your wound bed. But these are some examples of some common categories of wound dressings and when you might want to use them. But I think we have to be realistic, and despite this talk, I'm going to tell you what the literature says, and that is that there is no evidence that any wound dressing is superior to others. And this is based on my experience. I was the senior author for the Wound Healing Society Pressure Ulcer Guidelines. I have several other publications, reviewed a lot of Cochrane reviews, and basically not one of these has been proved to be better than another. And one of the things that I tell you, and one of the reasons why, is even in current clinical trials, there's a lot of problems. So here's an example. This is obviously if we don't have good wound dressings, it's a big problem. And venous leg ulcers is just one of the kind of lower extremity ulcers that we see. They account for 70 to 90% of lower extremity ulcers, 600,000 annually, 1.7% of patients over age 65 have a venous leg ulcer, and 2 million working days per year. So a huge problem. But the money that's being invested in it is low. From a wound research standpoint, we get the same amount of money as Fragile X syndrome, and I'm sure all of you know what that is. And we get 0.15% of federal funding budgets. 2% of the population at any given time has a chronic open wound. And there have been no new pharmacologic treatments in over 12 years. So we're behind the 8 ball. So, we kind of have one hand tied behind our back. And I think one of the reasons why is biofilm. So the CDC estimates that 65% of all human infectious diseases caused by biofilm. NIH puts that number closer to 80%. These are the organisms that are most commonly isolated in an acute wound setting in a burn unit, and they're all biofilm-producing bacteria. And a recent meta-analysis by a fairly distinguished group of biofilm experts shows that biofilm is ubiquitous in chronic wounds. So again, we're talking about lower extremities. This is a scanning electron microscopy of an acute burn wound. So this is 3 days out. This is a gentleman that had his burn excised to fascia, and then we took a biopsy of the fascia, and here are some gram-positive cocci and what certainly looks like extracellular polymeric substance. So it's there. There are certain criteria for recognizing biofilm infection that has to be adherent to a surface. You have to be able to show the extracellular polymeric substance. It is confined. And then the big one is, of course, the resistance to antibiotics, even though when it doesn't have that EPS covering or that biofilm state, it should be susceptible. So the big thing about this and understanding this is not only do I think it's a major confounding variable for understanding dressings, but it will also convert your acute wounds to chronic wounds. And just some data to show this, we published this paper on patients with sternal wound infections. Our fellow was going into cardiac surgery, and so we took 6 patients going to the ORs with known sternal wound infections. That's what SWI stands for here, and 3 that were going back for elective sternotomies, and we basically took the sternal wires and examined them. And what I want to show you here is only 1 of the 6 that we know had a sternal wound infection had a positive wound culture. So if you've got a bacteria in a biofilm state, it's not going to grow reliably in culture. And this is just to show you, here's an example of one of the wires. This is with a non-sternal wound infection. This is amplified. This is likely just fibrin. And here's the sternal wound infection wire, where you can see the wire itself is coated in extracellular polymeric substance. Here's the EPS, and here are the gram-positive cocci. So bad problem, hard to diagnose, and again, confounding variable. So why is it that these convert your chronic wounds or acute wounds to chronic wounds? Biofilm bacteria degrade soft tissues. So the bacteria themselves will express ceramidase, the primary lipid in the stratum corneum. They activate human matrix metalloproteases. They induce neutrophil respiratory bursts with release of elastase, and the bacteria themselves will express lipase. So pretty much you're enzymatically degrading every single subcutaneous surface around this biofilm infection. And I think this is particularly telling. For me, osteomyelitis, this is classic about why you get a sinus tract above a focus of biofilm infection in osteomyelitis. What else does biofilm do? It's a formidable foe. It attracts neutrophils, the first line in innate immunity, by releasing planktonic bacteria, releasing LPS, releasing bacterial DNA and exotoxins. All of those are chemoattractants for neutrophils, and then the neutrophils essentially get trapped in the CPS, and they will release their reactive oxygen species, that again the biofilm is impervious to that. When the neutrophils get trapped in the CPS like a fence, they basically die. So they are induced to produce what's called apoptosis, and in the biofilm world this is specifically called netosis. And then the bacteria, now that they've trapped them and killed them, they eat the neutrophils as a nutrient source. So they're incredibly efficient. And as one of the other things that they do is they modify their phenotypic behavior so they become recalcitrant to antibiotics. And so this is the main mechanism through which the antibiotics are rendered ineffective. They do this by decreasing their cell division rate, so the very low metabolism. The EPS will itself bind to aminoglycosides. So basically these don't work, and it's one of the hallmarks of biofilm infection. So the key here, and this is why I put this in a different color, you can overcome this temporarily through disruption of the biofilm, and for us as surgeons, that's debridement. So debridement is a really critical factor, and you have about a 72-hour window before that biofilm will get reestablished. So I'm going to give you an example of how, knowing this paradigm, I try and use my gauze and wounds and gauzes to help me heal wounds. So I like this case because it's a 17-year-old kid who is an elite athlete. This young man is trying to get a scholarship in wrestling, and he's got this open wound that's been grafted 3 times by one of my colleagues in general surgery. So he gets sent to me to get a flap. So I've got a wrestler with this little wound who can't go back to practice and he can't get this to heal, and I'm not going to do a gastrocs, right? He had a tissue biopsy. This is a very good surgeon. It grew staph. It was supposed to be susceptible to Bactrim, but he didn't get any response. So what did I do? I did not do a gastroc. I did weekly wound debridements in the office, topical Bactroban, and Bactrim for 10 days. So the weekly debridements to disrupt the biofilm, really important, add the topical antimicrobial for wound healing basics. Many times IV antibiotics don't penetrate granulation tissue, so you have to add a topical. And then I did give a systemic on top of it because I really wanted this kid to get healed. So here's another way. I do a lot of pressure ulcers, and I'm going to show you a lower extremity reconstruction where there's biofilm most likely. Again, here's a Pseudomonas in a planktonic state. You see the rods just hanging out there. Here it is in a biofilm state. We have a wound tissue bank. Here's a pressure ulcer. This is loaded with biofilm, and you know that's going to happen. So again, here's the gram-negative rods. Here's the EPS. And this meets all the criteria for biofilm infection. So how do I take this information and change the way I practice to get my wounds and my goos and gauzes to work? Here's a gentleman with a trochanteric pressure ulcer. So he's got a femoral head, osteomyelitis. We've done a girdle stone. We've resected the femoral head. Here is the very edge of the femur, or no, here's the edge of the femur. And the other really critical thing is I have the orthopedic surgeons ream the acetabulum. If you look in there, it's covered with granulation tissue, and frankly, that's a marker for me that you've got a biofilm infection. So they ream the acetabulum. I put these absorbable hydroxycalcium apatite beads. They are impregnated with Vanco and Tobra, and then I throw my vastus lateralis flap in there. And when we looked at my patients that had, and this is all comers, so I looked at every single one of my patients where I had a 12-year follow-up available. We had a recurrence rates, so we just started doing this. We had a recurrence rate that dropped from 40% to 12.5%. And if you look particularly at our recurrence, none in our sacral, and it just isn't adequately powered to allow us to do statistics in this area. Cut our ischial recurrence rate in half, and again, none in our femoral head osteomyelitis. So the one other caveat is those beads can cause seromas, which we did see in this patient population. But again, I think it sort of is a proof of concept that if you have to add the aggressive debridement with a topical, and in all of these cases with osteomyelitis, with a systemic antibiotic in order to try and overcome this. So you're going, great, what I haven't really given you any recommendations, and what do I use? So I'm going to tell you about some dressings, this one dressing where there is some evidence of effectiveness against biofilm. I'm not going to tell you I use this routinely, I don't, but there are very few out there with direct evidence of efficacy against biofilm. And again, here is a placebo where we grow this in culture, and I'll show you how we do this with the Pseudomonas. And if you have this dressing, it's a printed polyester with zinc and silver that creates a small current that's showed here, and you actually can see that it penetrates through the subcutaneous tissue, and these bacteria are connected by little, what they call biowires, and that electrical current disrupts those biowires, so they can't do quorum sensing. So that's how we think this works. And then this just shows you, again, you've got these dressings embedded in this agar, and we grow this biofilm-producing Pseudomonas over the top, and you can see the relative area of resistance with the imprinted polyester as opposed to the plain polyester. Again, no disclosures, so I don't get money from the polyester people or the hydropharablue people. I like this dressing. It's a foam, so it's absorbent, great with venous leg ulcers. You can leave it on for many days. It's relatively inexpensive, and we have a great rep in Byram that supplies it for us. So just one of the other opportunities or fancy wounds or gauzes that you can use. So in summary, your fancy wounds and gauzes only work if the wound is routinely debrided. I think you should just assume that there's biofilm in the wound, especially for those chronic wounds. Pseudomonas, just so you know, is in everybody's water, so it's going to be in there. And then I try and select dressings that are tailored to each wound with regard to cost, exudates, and the frequency of dressing changes. So we will go on to Dr. Orgill next. Thank you.
It's great to be here today, see so many of my friends, and hopefully something will show up here. I guess I can talk about my preferred techniques and facelifts and get everybody's attention. Here we go. We're talking about negative pressure wound therapy, which I actually hate the title because there's no such thing as negative pressure. PV equals NRT, for those of you that can remember. I have lots of disclosures. I'm totally conflicted. But in 1997, my friend Carl Brewing brought the VAC device to the Brigham. And no one really thought this would work. You know, you put this thing on, you suck on wounds, but then we started putting it on and we saw some remarkable things, as most of you in the audience have seen. Here's a woman who, she was a vasculopath and got necrotizing fasciitis, and this is her leg off at the hip with her hip joint here exposed. And, you know, we were always taught, and she's got a colostomy over here. So we were always taught you need like a flap to close this, but we couldn't do it, so we put this device on, and here she is with a skin graft. And then for skin grafts, these work very well on skin grafts, and there's actually pretty good data to suggest that this is a great way to bolster your skin grafts. Now, good things and new ideas are hard to introduce, and this is Louis Argenta and Mike Moriquas, who were the inventors of the VAC device, and they submitted this and it got rejected, and it eventually showed up in Annals of Plastic Surgery, and these two are the most highly cited papers in all of plastic surgery now. And this has really changed the way we do in wound care, and I won't ask the question because I can't imagine anybody here is not aware of these devices. But we got interested in these because everybody said that this worked by just taking out a bunch of fluid, and we would put this on wounds, and we didn't get that much fluid out, but we see this remarkable granulation tissue form. And so we came up with this idea of microdeformation in terms of stretching cells and getting them to divide and proliferate. And this was done by one of our medical students, and this we believe is an important mechanism. And these devices are basically mechanical devices that we're putting on wounds, and we're applying forces at the microscopic level. But at the macroscopic level, this can also work, and this is Mahendra Daya of South Africa, who can take simple tape and get skin expansion. And this is a technique that I've adopted in my practice and can be quite useful. So one thought is, for example, in lower extremity trauma, which Nick will talk about in a few minutes ago, we used to do lots and lots of free flaps, but we do many less now than we used to. And one of the things we believe that some of these new technologies that are coming along allows us to do simpler operations. And this is just an example of a sternal wound where we use this on. You can see we cut the sponge a little smaller than this. We put a non-adherent layer over the heart and we put it on, and this pulls the wound together, which was really one of the original ideas that Argenta and Moriquas had. It pulls it together and stabilizes the wound so that the patient doesn't require to be on a ventilator and can be in the cardiac unit before they're closed. But with all this that we've all seen, you look at the literature and say, well, does this really work or not? And there's a bunch of people that have gone back and done reviews. Here's one from 2008, said that there's not insufficient evidence. And then people did it again, a Cochrane review in 2015, and shows that there's a lack of evidence for both the benefits and potential harms of negative pressure wound therapy, and we need better research. And I think part of this is that we apply these devices on a lot of different wounds, people of different age groups, different disease states, and it's hard to get outcomes. And the other thing is we don't necessarily apply these until the wound is closed. We put it on for a while, and then we'll do a skin graft or a flap. And so why are there so few quality studies? Well, one is that right now these devices have a fairly low bar to get over to get through to the FDA, so there's not a lot of motivation to do the studies. The studies are really expensive to do. It probably costs $10,000 to $15,000 a patient to do one of these studies. And then one of the big problems, we tried to do a couple of these studies at our institution, and a lot of people would push back and say, well, we know this works, so why would we compare it to the placebo? And it's difficult to do the inclusion and exclusion criteria. So I think some of this we'll end up doing in the future by doing registry studies. So there's been a big explosion out there, and in 2017 there are lots of new devices out there, and people think that this is going to grow at about 6% per year, and there are new things like for incisional use on high-risk incisions, and a lot of new technologies to make these sort of faster, better, cheaper devices. And how this is all going to sort out is a little difficult to tell. So now I'll show you some good and bad and ugly, but we see these these come into our wound clinic, and you take this off, you never know what's going to come underneath. But if you put one of these devices on something that's dead, it's not a great idea. You got to take off the dead first. And then you have to put it on right. And these are put on by all sorts of people that don't necessarily know how to do it. They won't cut the sponge to the right size. They'll overpack the wound, and they won't document how many sponges they put in, or remove everything from the track. The interface device is critical. If you want to induce granulation tissue, you want to use a foam. If you don't want to induce granulation tissue, for example, over the bowel or over a nerve or a blood vessel, then you need to put a contact layer. So you need to know when to use it and when not to use it. The anatomic layer is important, so a bridging technique or putting something like duoderm around it can be very important so you don't get pressure necrosis. And this is a guaranteed medical legal action. If this guy shows up to our clinic and wondering why this wound won't heal, the vac's been on for 3 months, and our nurse astutely went in and started looking around and found some retained foam. And once we took this out, it actually healed. Sometimes you need to take a break. These do cause skin irritations. Sometimes they'll get a little smelly. We oftentimes use Dakin solution, and then we can resume 24 or 48 hours later. When do you stop it? Well, if it's not working, you have to go do something else. We generally will not do this longer than 3 months. We'll look at weekly wound measurements and make sure they're contracting. So some case studies: really nasty venous stasis disease with some of Gail's biofilms right there in the green, Pseudomonas. And so we used actually a silver impregnated sponge on this and could get him skin grafted. There's a lot of interest in incisional NPWT, and we do use it on high-risk patients, but I think we're going to have to decide who's high risk, who do you use it on, what's the best device, can we make these more comfortable and smaller for our patients. So there's a lot of innovation in this area. Unfortunately, not a lot of great data to support it. And then just to show you some examples of how this works when it works well, you can see just this device alone over a period of a few weeks can close a wound. Here's another example. Here's a young woman from Africa who came, and she actually had one of these devices put on over there. They amputated her toe, and then she was a ballerina, and she had this little extensor tendon, and she wanted me to keep it. So we did this for a while, and then put on a bilaminate dermal scaffold and a skin graft, and she's back in Africa now. Sometimes these devices have been so successful that people just put them on everything and assume everything's going to heal. But here's an elderly woman, 79 years old, with an open fracture, external fix. And, she came to us 3 weeks later with a vac sponge on. It was clear to me this wasn't going to work, and so we did just a vastus lateralis with a non-mesh skin graft. You can see that 6 months later, she has a great contour, doesn't need any debulking. And then here's a lady with purpura fulminans who, she had this on both sides, both feet, as you can see. And so we used one of these devices and then used a bilaminate skin substitute, and were able to get her healed. Most people, she was too sick to do free flaps on, and most people wanted me to amputate, but here she is several years later, and she's actually walking on these. So there's some things you can get in trouble with when you use these devices. The main thing is using it over the heart or big blood vessels, particularly in the groins. And there have been deaths reported, 12 and 174 injuries to the FDA since 2007. So be really careful on people who are anticoagulated, particularly when you're using them outside the hospital, in home or in nursing homes where you don't have a rapid response team. There's a temptation to save some money and use the wall suction, but there have been cases where the wall suction, these are very efficient devices that eliminated blood, and the patients can die. So these are the contraindications that we talked about. Necrotic tissue, you don't want to put this over bad infections like osteomyelitis or exposed nerves or big blood vessels. Again, another thing about bleeding, be very careful about the bleeding. So in conclusions, this has been a big change for wound care. I don't think there's any other device or drug out there that's had a bigger effect in the last 20 years. We still need better data. I think a lot of this is going to come from registry data, but as these new products are developed, hopefully we'll be able to get some comparative clinical trials. With anything, you need to use these with caution. Be very careful with bleeding, particularly when we use these in sternal wounds and around the groin, can get into a lot of trouble. They need to be properly debrided. This is not substitute for bad debridement. Be careful with things like pressure necrosis, skin maceration, and it doesn't work on everybody. So if it doesn't work, you have to do something else. And be careful with retained material. If you put it in, I like to use one piece, but if you use more than one, you have to document and make sure whoever takes it out gets everything out. And then be careful in putting foam directly on things like bowel or bladder, because you can get a perforation. Anyway, I'd like to thank you for your attention, and I think we'll turn it over to Nick.
Thanks very much. And Paul and Chuck, thanks so much for putting this on. I mean, it's just great to see the attendance out there. I see in the audience some of my personal reconstructive surgery heroes. I see PG Arnold over there. Hey, PG. I want to see that doodle when you're done with it. But this is really neat. I'm Nick Vetter, and this was the title that I was given, so I quickly changed it to What Works in Lower Extremity Reconstruction, because a lot of time the tried and true is what really works. I'm from the University of Washington. I'm basically a hand surgeon at Harborview, which is the only level 1 trauma center for a third of the U.S. landmass and 11 million people, but our hand service does all the lower extremity reconstruction too. So the basic principle when we're dealing, especially with trauma in the lower extremity, is to look into the crystal ball down the road and try to determine will the patient be better off with salvage and reconstruction or better with the amputation, because we do have good prostheses for the leg. You want to make that decision at the time of injury, not 6 months down the road. And it's all about deciding between reconstruction versus prosthesis. It's the cost, both acute and long-term functional status, what's their employment need, what are their daily needs, what are their long-term goals. So, you know, we have a case like this where you have a bilateral foot amputation from a wire on a ship. And you look at that and say, wow, well, bilateral BKs, we could put them back on, but is it the right thing to do? Well, we went ahead and did. This one here developed a mycotic aneurysm, blew out, and he lost that. And so for the first 2 years, he was much happier with his prosthesis until his pain subsided on the left side. He started to get sensation back. And for the rest of his life, he liked his replanted foot. So sometimes it is the right thing to do. It's all about patient selection, age, health, smoking, vascular disease, other injuries. What are their functional requirements, balancing complexity with patient needs, and balancing form and function. In the end, for the leg, you want something that's stable, durable, flexible over the joints, And contour is important for the leg, is mostly for aesthetics. In the foot and ankle, contour and low profile are important for function, for footwear. It has to be no shear, very flexible, exceptional durability, and stability is more important than sensibility. Certainly in the case of trauma, which is most of what I do, excisional debridement is the most important of all. And then move on to vascularized coverage of what I like to call the white structures, bone, tendon, ligament, and nerve. In the lower extremity, less can be more. Not every wound needs a flap. I do personally still like Steve Mathis and Fouad Nahai's reconstructive ladder, where you start with the simplest thing and move up to the more complex thing. There's Steve autographing his textbook for me. Larry Gottlieb said, well, that doesn't make sense at all. You don't want to do something simple and have it fail and then just walk your way up the ladder. You want to take the elevator up to whatever floor you need to get off at. And so I asked Fouad about that, and he said, the reconstructive ladder was never meant to be a rigid algorithm confined to choosing the simplest method, but instead was merely a framework to consider all the various reconstructive options available in light of their cost, risk, benefit. So really they're talking about the same thing, and so I'll still talk about the reconstructive ladder myself. Don't merely use the simplest technique possible, use the simplest technique that will achieve optimum form and function. Don't be afraid to choose a complex reconstruction if it's going to provide the best result, but not everything needs a free flap. So your choices are based on the quality of the reconstruction, type of tissue, function, durability, shape, contour, aesthetics, and not whether it's a random pedicle or free flap. Planning the reconstruction, well, what components are missing? What are the functional requirements? What secondary procedures are going to be needed? Grafting, implants, et cetera. What are the durability requirements? And what about the contour and aesthetic requirements? And then based on this, you choose the simplest method amongst the myriad of options that we have that will achieve optimal long-term outcome, both functional and aesthetic. Consider both local and distant options, and very importantly, consider potential donor site morbidity. So starting at the bottom of the rung, primary closure, this is from Steve Benershka, who's one of the orthopedic foot and ankle surgeons I work with, who is the best soft tissue surgeon I know. I never get consults from him because he doesn't have complications. Primary wound healing is often achievable. This is a case of his with exposed hardware. Obviously he needs a free flap, right? Not in Steve's hands. Take out the hardware to debride the bone, undermine a little bit, row of Donati sutures, and get primary wound healing. So vascularized coverage is usually indicated, though, when there are white structures of bone, tendon, joint, nerve, preventing breakdown, preserving length, and to help in prosthetic fitting. Do tendons count? Well, for me, leg tendons get no respect. So if it's dead, you got to cut it out. There'll be some left. You just suck on it with a vac, or you do dressing changes, and a couple of weeks later, you have a skin graftable wound. Same thing, a toe extensor. I'm not going to do any kind of vascularized coverage for that. Just make little debridement, some longitudinal incisions to induce some granulation tissue, and you can easily graft that a couple of weeks later. Achilles, infected Achilles repair. So these usually get to me several weeks out, and by that point, a lot of it's dead mush. You're not going to, this was sent for a flap. Well, you're not going to put a flap on this. You're going to debride it first. And once you do a big debridement, there's going to be, this is opening it up. That's after the debridement. There's a whole layer of scar tissue there. There's no need to reconstruct that. And in the end, you don't need a flap. You just put a vac on it, and a week later, you can put a skin graft on it. So, as Dennis says, the most significant advance in microsurgical extremity reconstruction is negative pressure therapy, because we, just like you, are doing a third the number of free flaps we were doing even 15, 20 years ago. On the foot, even with exposed hardware, the vac works well there. Exposed tendons, make some longitudinal incisions in the tendons. It'll induce granulation with the vac, and you can skin graft it. So the modified reconstructive ladder that Dennis showed does have negative pressure therapy somewhere in there. It's not always in the middle, but it's certainly in the mix. It does have limitations, so it's poor coverage for mobile structures. Prolonged immobilization can lead to stiffness, so it's really not very good in the upper extremity. In the lower extremity, it has a bigger role. And it can be overused, as with any new technology, which delays appropriate coverage. Something like this, no, you're not going to treat that with a vac. So flap selection, I think muscle and skin graft still definitely has an important role in lower extremity soft tissue reconstruction. It can be pedicle flaps, we have the gastroc and hemisoleus. Free flaps, we have the lat, gracilis, rectus, serratus. The advantages are it's very good vascularity, good environment for healing, malleable, and usually minimal donor morbidity. But in the end, muscle can't control dead infected tissue or bone, only excisional debridement can. So open tibia fracture here, certainly a hemisoleus will work very well for that and can just skin graft on that. Massive tibial osteomyelitis requires major resection of that, internal fixation. The lat flap provides a huge area of coverage with truly minimal donor morbidity, and you can come back 6 weeks later, lift it up, and do iliac crest bone grafting. So I think that muscle flaps definitely still have a role. Traumatic BKA with loss of the posterior flap. In this particular case, we used a free tram flap and used a little bit of muscle to cover the tibial stump, and we're able to salvage a BK and not have to convert it to an AK. So in the lower extremity, don't use more flap than you need. This is a 20-year-old slide with a big latissimus flap, way more flap than we needed. And the only way to get out of this is to shave it down with a Watson knife and re-skin graft it. Same thing with the gracilis on the ankle. So inset it securely around the pedicle, stretch it, score the fascia, stretch it, and remove any unneeded tissue. Insert it beneath the skin edge, and here's a case here with a free gracilis down to the ankle. Incising the fascia, stretching it, resect what you don't need, and if it looks flat on the table, it's going to look flat in the end. Another case here, gracilis and split thickness skin graft at 3 months. And you can see the nice contour that you wind up with. So weight-bearing surfaces on the sole of the foot. I still think that muscle and skin graft is often the best way to go. It's low profile, but most importantly, it's stable to shear. This is a case done by one of my colleagues, John Connolly, used a sural artery flap over the calcaneus. And the problem with that, it's a foot, not a breast. So this is going to slide back and forth, and it's going to ulcerate. And I think a muscle flap, in the end, is usually better. So here's a gracilis and skin graft on the sole of the foot at 3 months and at 15 years. Very stable, no breakdown whatsoever. So fasciocutaneous flaps definitely do have a role, either local or pedicled or free flaps, scapular, radial forearm, lateral arm, ALT. But I can also ask you to consider fascia-only flaps, and we'll get some examples of that. Not every distal third defect needs a free flap. Often just a local flap will do. And then judgment. Good judgment comes from experience, Mark Twain said, and experience comes from bad judgment. So here's bad judgment. This is my first ALT 25 years ago in a fat American down around the ankle. It has a built-in rain gutter there. Fortunately, most of it died, and I took it off and left the fascia, which was fine, and was able to put a skin graft on it. So foot and ankle, consider fascia only in skin graft. So here's a Lisfrank's fracture there with exposed tendons, exposed hardware, a giant ALT fascia flap with a big long pedicle provides a nice low profile, well vascularized reconstruction that you can skin graft on and still fit into a shoe. Deep burn with open TMT joints there, giant ALT fascia flap, skin grafted, and again, a nice low profile, durable reconstruction. So foot and ankle, as well as hand and wrist, consider fascia only flaps. Here's an open malleolar joint, lateral malleolar joint. And here taking the DP fascia. So the DP fasciocutaneous flap is a hideous flap. The donor defect is just horrible. But if you just take the fascia, you can do primary closure of the donor site and retain skin coverage over the extensor tendon. So here's elevating the DP fascia flap, tunneling it over to cover the ankle joint, and then primarily closing the defect. Perforator flaps definitely have a role. They have the advantages of skin flaps in that they're durable. They have a nice appearance. They can be innervated if you need to. They can be thin, except in fat Americans, in which case you need to really thin them. And the donor morbidity is usually limited if it's not too large. If it's big, the donor morbidity is going to be big. But here's a case of my partner, Jeff Friedrichs, with open ankle, beads in there, and a nice ALT flap that has a very nice low profile, good contour. Case of Peter Nelligan's, another one of my partners, for a melanoma reconstruction with a suprafascial ALT hooked into one of the digital nerves, so actually wind up with a sensate, low-profile reconstruction on the foot. Even though it's a little bit hairy, it works out pretty well. But perforated flaps aren't always a panacea. In a fat American, you can have a muffin flap if you don't thin it down very much. Case of one of my partners, Jason Coe, there's the defect. I mean, it's a third of the guy's thigh, and he had to do a keystone flap to close the donor defect, which then pussed out, dehisced, and it was a mess. So if they're big, the donor defect can be significant. Tissue expansion. Tissue expansion has, I think, extremely limited indications in lower extremity reconstruction. It's for secondary reconstruction only, otherwise they'll get infected. In my experience, 100% complication rate, but you generally achieve the goal. So here's skin graft over femur, put in a bunch of tissue expanders, expand them up, and oops, there's the exposed expander, as always happens. So you blow them up as fast as you can, go in, take them out, and in the end are generally able to achieve where you want to get, even though you do have complications. Now, I'll just finish with one of my favorite cases, a little 7-year-old girl who had both of her feet nearly amputated by a rope off of an inner tube, fixed the bone, used long vein grafts to revascularize it. Looked good at first, but eventually all of that died from the zone of injury. So went in and tried a perforator flap, a little propeller flap with the vessel coming right in the zone of injury, and so it looked good for the first 24 hours, and then started to look not so good. Peter Nelligan said, "It'll be fine, it'll be fine." I hate perforator flaps. So it went in the bucket, and we did a lat flap, and in the end, worked out really well. She got to go on having a normal life as a kid, skiing, and being a lead scorer on her lacrosse team, cutting right on her replanted foot. And so I got to give her the Patience of Courage Award at the ASPS in Boston the other year. So in the end, initial wound management is important. Patient selection, vac versus flap. Flap selection, consider fascia and skin graft, especially if it's around the foot and ankle. If you're going to do perforator flap, thin it, innervate it if you can, especially if it's weight bearing. And for the lower extremity, function over form. Debridement, vascularized coverage of white structures, low profile, durable, less can be more. Not every wound needs a free flap, and don't use more flap than you need. Thank you. Time for questions?
Yeah, thank you, Nick. We got a couple minutes for questions. I know you're all probably ready to get to lunch. Any questions? If not, I have one for Dennis. Do you use a vac on your muscle flaps?
Sometimes, but usually not.
Okay. What would make you? What's the delineating factor?
I worry about the movement if they're over the pedicle when it sucks down. So that's what I worry the most about. And it doesn't seem, the skin graft takes really well on the muscle flap, so there's not a huge reason to do it.
Yeah, I would agree. I don't do it on my muscle flaps. We have a question.
Thanks very much. Just two questions. What does the panel think of chemical debridement in the future regarding that? And secondly, previously, what you think is fully resected malignancy, the putting a vac on it, it's not quite clear from the guidelines, certainly from KCI, what to do in those instances. What you think of that?
Okay, so two questions, and I think for two different speakers, so I'll take the first one. So the chemical debridement, the biofilm is really adherent, so I'm not convinced that any chemical that you put on that's going to be sufficient to disrupt the biofilm is also likely to be toxic to the surrounding tissues. That would be the first thing. So I will tell you I'm not aware of particular claims, and I could be wrong, but I'm not seeing that as a particular strategy unless it's specifically targeted to biofilm, quorum sensing disruptors, but you still have the mechanical barrier of the EPS. So that's what I would say about that. I know there are claims that Dakins and some of those other products out there will do it, but unless they're showing you a before and after with the actual biofilm and the disruption of the biofilm, I would be very skeptical. So Dennis can take the second question.
Yeah, we do put a vac on, and for a lot of ours, we don't trust frozen sections, so we take it off, put that on, wait for the permanent sections, and then if there is a positive margin, it doesn't seem to matter. So.
And one last set of housekeeping things. The meeting annual evaluation will be sent on March 31st. Please complete the summary so you can get your CME. Be sure to visit the exhibit hall and attend tonight's reception in Lone Star E. Thank you.